Welcome to the Euvie Podcast, specializing in gynecological education. Today's episode will be about the fallopian tubes. The fallopian tubes are named after Gabriele Fallopio, a 16th century Italian physician and surgeon. The tubes are a pair of very important structures in the female reproductive system. According to the Encyclopedia Britannica, the fallopian tubes are each about 4 inches long, and they play a crucial role in many processes of the female reproductive system. The tube has 3 layers, the innermost called the mucosal membrane, the middle muscular layer, and the outer thin layer called the serosa. The mucosal membrane is made up of 3 different types of cells. These are secretory cells, which make up 60% of the membrane's composition, columnar ciliated epithelial cells, which make 25%, and narrow peg cells, which make 10% or less of the membrane's composition. The membrane contains many folds and small cone-like projections called papillae. The fallopian tube is split up into 5 different sections called the fimbriae, the infundibulum, the ampulla, the isthmus, and the interstitium. The fimbriae of the fallopian tubes are the parts of the fallopian tubes that are the farthest from the uterus. The fimbriae are connected to the ovaries, and they are the small, finger-like structures that sweep the egg from the ovary into the tube during ovulation. The fimbriae then deposit the egg into the infundibulum. The infundibulum acts as a funnel for the egg, guiding it closer to the uterus. Next comes the longest portion of the fallopian tube, the ampulla, which is on average about 5 centimeters long. The ampulla is the site where fertilization of the egg with the sperm occurs. Hence, the ampulla is also the site of most ectopic pregnancies and tubo-ovarian abscesses. Both the ampulla and the infundibulum are connected to the uterus by the thinnest part of the fallopian tube, the isthmus. According to the Global Library of Women's Medicine, there is some evidence that the isthmus may act as a sphincter. The final section of the fallopian tube is known as the interstitium. According to the Geneva Foundation for Medical Education and Research, the interstitial portion of the fallopian tube empties out into the uterine cavity and is about 1 centimeter long and 1 millimeter in diameter. Blocking the fallopian tubes is a method of sterilization for women who no longer wish to have children. According to the Geneva Foundation for Medical Education and Research, some of the most common methods of female sterilization are techniques such as the Madlener, Pomeroy, Irving, Uchida, and Kroner technique. The Madlener technique is the looping, crushing, and ligation of a fallopian tube. Because the tube is not excised, the Madlener technique has a slightly higher failure rate. The Pomeroy technique is the ligature and excision of a looped tube. The Pomeroy technique is the most popular method of tubal sterilization. This is because the Pomeroy technique is fairly simple and has very few complications. According to the Global Library of Women's Medicine, the Pomeroy technique is reported to have an average of 2 to 4 pregnancies per 1,000 procedures, implying a failure rate of 0.2 to 0.4%. Because only about 3 to 4 centimeters of the tube is destroyed, there's a good chance of reversal for the Pomeroy procedure. Reversal may be requested by patients when they change their minds and plan on having more children. The Irving technique involves the excision of 3 to 4 centimeters of the mid portion of the fallopian tube, and then the burying of the proximal and distal ends within the myometrium and the broad ligament, respectively. When the Irving procedure is performed in the first 4 to 6 weeks after delivery, it is very effective and has a relatively low failure rate. However, The Irving Technique has a poor reversal rate because 30% of the fallopian tube is destroyed. The Eugenia Technique is when the serosa is stripped from the muscular coat of the fallopian tubes. The mid-portion of the tube is then excised, and the proximal end is ligated and buried in the broad ligament. The Eugenia Technique is the most efficient and complex of these procedures, and it is associated with a very small amount of failures. However, because the Eugenia Technique destroys 50% of the fallopian tubes, it has a very poor rate of reversal. The Kroner technique involves performing a fimbrectomy, removing the fimbrial ends of the tubes, which is not very popular now due to new and more efficient techniques. Apart from sterilization, the fallopian tubes can also be the site of fertility treatments to help people conceive. These techniques, called assisted reproductive technologies, or ARTs for short, always involve the removal of the oocyte, or the female gamete, from the ovaries. In the case of in vitro fertilization, the oocytes are incubated in a test tube with the spermatozoa, or the male gamete. The cells are monitored for 18 hours to see if fertilization has occurred. Then, after the zygote is formed, it is cultured for an additional 24 to 48 hours before being returned to the uterine cavity. Alternative methods involve the transfer of the embryo to the fallopian tubes instead of into the uterine cavity. These methods are known as embryo transfer methods, or ETs. One such method is the Zygote Intrafallopian Transfer, ZIFT method. It is a method in which the zygote is transferred to the ampulla of the fallopian tubes after 18 to 24 hours of in vitro fertilization. Another method is the Gametes Intrafallopian Transfer, or GIFT method. In this method, the gametes themselves are placed in the fallopian tubes. Usually, about 4 oocytes and sperms each are placed in a special catheter and then delivered into the fallopian tube, where they are allowed to fertilize within the fallopian tube. As amazing and versatile as the fallopian tubes are, they are also susceptible to many different kinds of diseases. Some of these diseases are rare, for example, an ectopic pregnancy. Ectopic pregnancies are rare, but are still very serious. According to the Geneva Foundation for Medical Education and Research, the rate of ectopic pregnancies has increased in the last 2 decades, from 4.8 ectopic pregnancies to 20.9 per 1,000 live births. However, the mortality rate has decreased from 53.2 deaths to 5.3 deaths per 1,000 cases in the same time period. Still, ectopic pregnancies remain the second most common cause of maternal mortality in the United States. An ectopic pregnancy occurs when, after fertilization has occurred in the fallopian tube, the zygote, instead of moving to the uterus and implanting itself and growing within the uterus, implants itself in the fallopian tube and grows there. This situation is more likely to happen when there is an anatomical abnormality in the fallopian tubes, such as scarring, constriction, or endometriosis, which prevents zygote movement into the uterus. Because the fallopian tubes are not meant to support an embryo, no ectopic pregnancy can be carried to term. If an ectopic pregnancy is not removed soon, for example, within the first 2 to 3 months of becoming pregnant, the fallopian tube could burst, even killing the mother if not operated upon immediately. According to the Mayo Clinic, some of the most common symptoms of an ectopic pregnancy include pelvic pain, vaginal bleeding, a missed period, and breast tenderness, making an ectopic pregnancy seem like a normal pregnancy. A pregnancy test will show a positive sign when taken, but an ectopic pregnancy cannot be carried to term. Ectopic pregnancies are usually identified only on scans. On the other hand, there are some diseases of the fallopian tubes that are fairly common, such as pelvic inflammatory disease. Pelvic inflammatory disease, or PID for short, is a disease of the female reproductive system in which the upper reproductive tract is inflamed as a result of being infected. The upper reproductive tract includes the ovaries, fallopian tubes, and uterus. The lower reproductive tract includes the cervix and vagina. According to the Geneva Foundation for Medical Education and Research, the cervix contains a jelly-like substance that acts as a barrier, protecting the upper reproductive tract from external viruses and bacteria that often enter the reproductive system through sexual contact. This is called a mucus plug. When this mucus plug in the cervix is compromised or breached, be it through a miscarriage, delivery, or cervical surgery, it is unable to prevent pathogens from entering the upper reproductive system. Because of this lack of a barrier, sexually transmitted pathogens may enter the upper reproductive system and cause infection and inflammation. According to the Mayo Clinic, some of the symptoms of pelvic inflammatory disease are common and often overlooked. Symptoms include problems such as irregular menstrual bleeding, fever, pain in your lower abdomen or pelvis, excessive foul-smelling white discharge, backache, or difficult urination. However, one should seek immediate medical help when vomiting, fainting, severe lower abdominal pain, or high fevers are experienced, which indicates more severe infection needing immediate medical treatment or even surgery in some cases. According to the Geneva Foundation for Medical Education and Research, the long-term effects of pelvic inflammatory disease are fairly extensive. About 25% of those with PID suffer an episode of salpingitis, which is a condition in which the fallopian tubes are inflamed, or experience recurrent PID. Pelvic inflammatory disease has long-term sequelae too. 1 out of every 5 patients experience chronic abdominal or pelvic pain. 2 out of every 5 patients experience Fitzhugh-Curtis syndrome, and 4 out of every 5 patients experience continuing menstrual disturbances, just to name a few of the long-term effects of pelvic inflammatory disease. To conclude, the fallopian tubes are a very important aspect of the female reproductive system. They help to carry an egg to the uterus and assist in fertility. They are also the site where the sterilization procedure is carried out. However, the fallopian tubes are also susceptible to disease, much like any other organ in the body. If you experience any of the above-mentioned abnormal symptoms or changes, please talk to your doctor. Please remember that this podcast is not a substitute for medical advice, and that if you experience anything abnormal, please consult a medical professional. Thank you for tuning in, and we hope to talk to you again.